Okay, it's 1:02. Let's get started. Okay, hello, everyone. Welcome to the Penn State CTSI BERD Seminar Series. My name is Lan Kong. I'm professor of biostatistics in the Department of Public Health Sciences. So this seminar series is organized by CTSI board core. So it's the fall seminars organized by the BERD core at Hershey campus, and the spring seminars organized by BERD core at University Park. So for the fall seminars, the co-hosts include myself and my colleague, Dr. Murphy and Dr. Zhu. So we have 7 excellent presentations line up for this fall semester. You can register for any of these seminars through the link on the CTSI website. There you will also find a link to the past recordings of BERD seminars. So for those who join us for the first time, I would like to inform you that this Zoom session is being recorded. Please mute yourself during the presentation. You can submit the questions using the chat box. At the end Q&A session, feel free to mute yourself and turn on the camera. If you register for the seminar already, you will receive the slides recording link and the seminar feedback survey. So now today is my great pleasure to introduce our speaker, Dr. Shen. Dr. Shen is a professor of surgery and public health science. She is the division chief of outcomes research and quality in the Department of Surgery. Dr. Shen is a health economist, econometrician, and biostatistician by training. She has 17 years of health services research. Before joining Penn State, Dr. Shen has been the assistant professor at Georgetown University, and then assistant to associate professor at the University of Texas, MD Anderson Cancer Center. She has extensive experience leading multidisciplinary teams on health outcomes projects using large existing databases. She has co-authored over 170 publications in this field. In 2022, Dr. Shen received the Excellence in Career Mentoring Award at Penn State College of Medicine. So today, I'm so happy that Dr. Shen will be able to share with us her experience and expertise in health outcomes research using large databases. So Dr. Shen, please take it away. The floor is yours.
Thank you very much, Land, for a very kind introduction. And I guess I can share my screen now. Okay. Let's start. Okay, so today's talk is about health outcomes research using existing databases. Thank you all for joining this talk. And we'll get started. Okay, a little bit roadmap of today's talk. I will start by introducing outcomes research and observational data. We will talk about some important issues when using observational data. I will also introduce some common approaches to analyzing observational data and touch upon the big data, machine learning, and AI, which is a fast developing recent research direction. I will give some examples of existing databases I personally have used before, and then some examples of their application in outcomes research, covering both traditional analysis and machine learning projects. And we end with implications of outcomes research with observational data. So we begin with introduction about health outcomes research. This is the field that I've been working on for many years. Outcomes research focuses on understanding the end result of healthcare practice interventions, and that's why it's called outcome. It's not the beginning of treatment. It's not designing new drugs. It's outcomes research. We measure how healthcare services, treatments, and policies impact the patient's outcomes, including quality of life, morbidity, mortality, a wide range of things. And we aim to improve patient care by identifying best practices and areas needing improvement. There are many uses of outcomes research, and one big important goal of outcomes research is to support evidence-based decision-making in clinical practice and also in policy designs. And we'll talk about the implications at the end of the talk as well. There are many different types of observational databases. Here are some examples. This is by no means comprehensive and includes everything, but these are most commonly seen observational databases. Number one, I guess everyone's familiar with this, with the technology improvements. Electronic health records is a very common data source. It includes a lot of detailed patient data from their healthcare providers. It includes patients visiting a hospital, for example, coming to Penn State Health. And then we get patients' demographic information, age, race, gender, and obviously a lot of biometrics data, their weight, their height, blood pressure, all sorts of things in the electronic health records and what kind of treatment they received. And results are often also monitored. Let's say the patient was sent to get a lab test, and we get the lab test result there too. A second big category is administrative claims data. And one example is insurance claims. Let's say Highmark, right? We have Highmark insurance. And then Highmark would collect all the claims information they have from patients and providers, the patient's demographics, what healthcare plan they have, what kind of treatment they received. Since all these healthcare visits of patients are usually submitted to the insurance for reimbursement purposes, it includes patient's diagnosis, treatments, and sometimes some outcomes as well. And the third category I want to talk about is disease registries. And disease registries are more focused. They are focused on tracking patients with specific conditions. As Len mentioned, I came from a cancer research background, so I'm familiar with many cancer registries. And I'm sure for other diseases, there are other registries as well. And the fourth one is surveys. There are many national surveys. The government spent a lot of money on collecting surveys that often have different focuses. These are large-scale surveys. They try to collect population health data. For example, NHANES. NHANES is more about health and nutrition. BRIFRS is another national survey, and that one is more focused on risk behaviors, behavioral choices that people make. And there are, again, many, many different surveys. The last one is a clinical database category. That category includes data from specific clinical settings or health systems for quality improvements. I'll just give some simple examples. In our own Department of Surgery, for example, there are clinical databases that capture trauma cases that Penn State Health has seen, and they collect very detailed information. For example, did the patient receive whole blood? How many milliliters did they get? When did they get admitted? When they get discharged? What was the outcome? What happened throughout the process? And for example, colorectal surgery group, they have their own clinical databases. They collected patients' information on all sorts of different things. And some often also include lab test results and specimens as well. Okay, there are many advantages of using existing databases. Number one, of course, is the cost. Because there's no need to collect new data, it reduces the time and expense. That makes it a lot more cost effective. Number two, we often get large sample sizes. For example, cancer registry has huge data numbers, and insurance claims, obviously, Highmark has lots and lots of records of patients. And it enables the study of rare outcomes and diverse populations. Third, the advantage of existing databases is often this is collected from the real world. It reflects the actual clinical practice rather than controlled clinical trial settings. We all know clinical trials, we often have sample that's kind of different from real world patient population. For cancer clinical trials, for example, we know the clinical trial participants are often younger, they are less likely to be minorities and things like that. So especially in cancer case, because in the end, it's going to be used on many older patients, it's helpful to have real world evidence. Another advantage of existing databases is we often get longitudinal data because we can track the patients over time. For example, insurance database. Suppose the patient is enrolled in an insurance plan for a long time, then that patient can be followed for a long time. Especially for Medicare, government insurance, because people above 65 years old are continually enrolled in Medicare. We can track those patients pretty well. I know commercial insurance, the longitudinal data part is not as great as Medicare, but still a lot of patients have long time enrollment and thus can be tracked. And lastly, because these existing databases are often based on real-world evidence, it helps inform policy decisions and clinical guidelines. Ethical and privacy considerations are important in outcomes research. Number one, patient confidentiality is very important. We need to ensure data is de-identified and securely stored. Pretty much all the data requests will need the principal investigator to sign something about patient confidentiality. Even if it's almost like open access public data, like national surveys sometimes, they still want the investigator to sign a DUA, data user agreement, to make sure that patient confidentiality is upheld. And compliance with HIPAA and other local regulations are obviously very important. Sometimes the existing databases still need informed consent. The data use may require retrospective consent or approval. So you need to go back and contact the patients about whether they are consenting to their data being used. And obviously, IRB approval is important. There are different levels of approval. allow me to say different levels of approval. But basically, the level of approval, it could be exempt, which is really fast. It could be a fast approval, or it could be a more deliberate, a committee for review. So it can take various different timelines. Exempt, I've had experience of exempt studies that take only a day. But I've also heard of full reviews that take much, much longer. And let's talk about the data quality and completeness of existing databases. There are obviously challenges with observational data in terms of missing data. We've all seen potentially records where certain fields are not filled, it's incomplete, and it could introduce bias and reduce statistical power. And our strategies, I see there are probably many experts on this call who knows imputation technologies and sensitivity analysis. Other than completely blank fields in the observational data, there can also be errors in the data entry or coding that could distort findings. For example, we are currently working on some projects where we look at blood transfusion in trauma. And we've seen records that are obviously wrong. People who receive more than 200 units of whole blood is probably not going to happen. So when we look at the data, we need to check and make sure, validate the data records and clean them as necessary. And when we use observational data, there can be certain bias and confounding issues. For example, there can be selection bias. Let's say the study population differs from the general population. Let's say we are using health, electronic health records from Penn State Health Institution data. Then if we want to generalize our findings to, let's say, the general US population, then it might not be the best data source, because Penn State Health has a patient population that's more white and potentially rural compared to the US general population. So it's important to select comparison groups and match and find the right study population so that results can be generalized to the target general population. There can also be information bias. There can be errors in measurement or classification of variables. Another example, for example, in a study that we're working on where we look at pain management of cancer patients, and we look at their pharmacy claims data. And we see some patients receiving super high level of pain management pharmacotherapy, meaning huge dosage of drug, which is most likely errors in the recording of the data. In that case, we have to improve data accuracy, validate these variables, check the data records, and make sure results are not biased due to these errors. And then there's also the confounding issue. Factors that influence both exposure and outcome might be making a difference in the observational database. This is kind of specific to observational data studies compared to clinical trials where you can control a lot of other things. So yeah, and the mitigation for the confounding problem is often multivariable analysis, propensity score matching, instrumental variable estimation, And nowadays, there are many, many more methods being designed and introduced. There's even causal inference in machine learning. It's a fast developing field. So there are limitations obviously of observational studies. Okay, number one, when we want causality, observational studies often only establish association and not really causation. There can be residual confounding. Some confounders may remain unmeasured or unaccounted for. For example, when we have a clinical database, we observe their weight, their height, all sorts of lab results, but we may not see how frail the patient is. And the physician, when they actually see the patient, they have a much better understanding of how the patient is doing. There's generalizability. Results may not always generalize to other populations. Like I said, let's say we only use institutional data, then it's hard to generalize to the whole US population. These are limitations. It doesn't mean there's no value in doing observational studies. We just need to transparently report those limitations and suggest future research directions, including potentially randomized trials, primary data collection, and so on. Three commonly used methodological framework for study design of observational studies are cohort studies, which means we follow a group of individuals over time to assess exposure-outcome relationships. It can be case control studies where we compare individuals with a particular outcome to those without and focusing on prior exposures. It could be cross-sectional studies, assess the exposure and outcome simultaneously in a defined population. And we'll talk a little bit about big data, machine learning, and AI. We're talking about observational data, and we know there is a huge amount of EHR data and all sorts of data. During the COVID, we know even cell phone data, where people are moving, where are they going. So there's a fast growing amount of data becoming available every day. And there's also a simultaneous increase in computational power in the modern age. And that enabled the analysis of massive data sets in real time. Here we talk a little bit about machine learning algorithms. The machine learning algorithms are often used to identify patterns, predict outcomes, and classify large volumes of data. And the AI trend doesn't only include machine learning, but many other things like natural language processing can be used to analyze unstructured data, such as clinical notes or social media. For example, we are working on some data looking at how people are responding to inflation based on Twitter data. Now it's called X, but there are social media data that can be used to look at people's sort of decision for health, how that relates to their other opinions, politics opinions, for example. And clinical notes is another great data source to mine and use natural language processing for. And last but not least, with the fast developing machine learning AI, it's important to keep in mind that there are potentials for machine learning and AI to exacerbate the health disparities problems. So we need to keep in mind the importance of health equity when we try to use machine learning and AI algorithms to help improve healthcare. Okay, this is kind of a dense slide with a lot of databases. These are all existing databases that I have personally used, and I try to categorize them into different groups, but obviously it's never going to be perfect grouping because some can be considered, in 2 or 3 different groups. Number 1, claims database. I have used Medicare database, Medicaid database, and market scan database. And the difference between these is obviously different populations. Medicare is mainly for older people who have Medicare insurance. They are above 65 years of age. Medicaid is for people who have eligibility for Medicaid, and Medicaid is a little bit more state specific. So Medicare is compared to Medicaid more uniform across different states. Medicaid can be different between different states. Market scan is great because it's for working age people mainly, because it collects information from insurance companies that provide insurance to employees mainly. So these are mainly employer-sponsored insurance, and therefore it includes a big number of patients who are working age. Number 2 is the electronic health records, and I personally have used Trinetics and Cerner. Trinetics is a national or even international database that's collected by hospitals, and they all sort of provide the data to this centralized data bank almost. While Cerner is what Penn State Health uses. And they are obviously different, but some of the Cerner data is also in Trinetics. Third, disease registries. Given my cancer background, and you can probably see all 3 examples are cancer registries. And you're probably surprised that we have different cancer registries. Now, number 1, the SEER Cancer Registry. This is a national cancer registry. And we say national, but it doesn't really cover every state. I think when I started doing cancer research back then, it covers majority of the states, but Texas was not part of it. Now Texas is also part of the SEER Cancer Registry. The registry, therefore, does not cover every state and every patient, even though it is a national cancer registry. Pennsylvania Cancer Registry data is another data source that I acquired after I moved to Hershey. So Pennsylvania Cancer Registry includes more data fields compared to the SEER Cancer Registry. It is Pennsylvania specific, obviously. It also has some additional fields compared to the National Cancer Registry. We have a bit more information about patients' residence and employment, which is not available in the SEER Cancer Registry. And then we also have the National Cancer Database, which is another cancer registry that's national, but this one is based on hospitals. So participating hospitals submit data to the National Cancer Database. Let's say a community hospital that doesn't participate in National Cancer Database, they could still send their patient information to SEER Cancer Registry or their state cancer registry. So they have a lot of overlaps, but not the same. Now we move on to the hospital discharge data. This is another big data source for hospitalizations. We have the HCOP NIS, which is National Inpatient Sample. We have the KID, and as you can imagine, the KID is for pediatrics. And it's also inpatient discharge. And we also have PHC4 data, which is specific to Pennsylvania, and it's basically Pennsylvania hospital discharge data. And I know there are also other hospital discharge data. Maryland also has one, for example. I know California has one. So there are many different hospital discharge data. I guess I forgot to mention the HCOP NIS doesn't cover every visit. It's more like a subsample of national inpatient discharge data records. Okay, and then quality improvement programs is another big data source. For example, here at Penn State, we have access to both the institutional specific Hershey Medical Center, NSQIP, which is surgery quality improvement program. And we also, as a participating institution, we also have the de-identified national data. And I guess this is similar to the relationship between institutional, let's say, Cerner data versus Trinetics data. We have more details that we can dig out in the HMC version, the institutional version, compared to the de-identified national data. And we also have pediatric version of the NSQIP. We have trauma, quality improvement. We have bariatric surgery, the MBS AQIP. So there are many different quality improvement programs, and they serve different purposes. And then there's a large categories of national surveys. I think I touched upon the behavioral risk factor surveillance system, which has a lot of information about behavioral risk, people's decisions, such as smoking, alcohol consumption, things like that. There is medical expenditures panel survey. This one is more focused on healthcare cost and expenditures. The National Health and Nutrition Examination Survey has more information about nutrition, obviously. And then National Health and Aging Trends, that one is for aging. And Health and Retirement Study includes more about retirement decisions, and it includes a lot of information that's related to aging as well. So it has, for example, people's financial worth and their decision about retirement, where are they putting their money, and obviously health too. There's Health Information National Trends Survey, which is more about the information technology. For example, we've looked at patients' decision to use cell phone or online apps to get health information. It has more about patient education and how they use information and how they communicate with their physicians. We have National Ambulatory Medical Care Survey, which is obviously more focused on ambulatory care. We have National Health Interview Survey, and this is only a limited list of national surveys. There are many more available. And the last category, I call them linked databases, because they are databases that are linked together. For example, we have SEER Medicare, which is the cancer registry we just talked about, linked with the Medicare claims. So patients who are above 65 years old who have Medicare and they are also in a cancer registry, then these patients' records can be linked together. That way you will see what insurance plan. Medicare still has different plans and different deductible and donut hole and all these things. Pharmacy insurance for Medicare, things like that. And I've also done the linkage between CM Medicare and American Medical Association Physician Master File, which basically supplements the CM Medicare with detailed information about healthcare providers. So it can include the healthcare provider, basically the physician's license, which subspecialty they work in, when were they trained, female, male, location, things like that. It is helpful when we want to look at patients' healthcare seeking behaviors. And then there's many other examples like Medicare Current Beneficiary Survey with linkage to Medicare claims. That way we have both their survey component and their actual claims. So the surveys might ask questions about their satisfaction with the services they're receiving. How do they feel? Do they have any limitations in their daily activities, things like that, which is not possible in the claims. But then it also has a claims part that gives us detailed information about the healthcare visits they've had, how much they've cost the Medicare program, things like that. And then there's also Veterans Health Administrative data linked with Medicare and Medicaid. Indeed, that's where I started when I was a PhD student. That was what I did as my full-time job. Actually, I worked on linking the Veterans Health Administrative data with Medicare and Medicaid claims so that we get a full picture of how veterans are utilizing healthcare. So a lot of databases. If any of these interest you, feel free to contact me. Okay, so databases available. I'll give some examples and talk about their pros and cons. For example, the NSQIP is a surgery quality improvement program. We have both the institutional one and the national one. And it's important to note there are, again, different types of data. There can be just a general one and there can be procedure targeted. So let's say we're interested in specific one. Let's say we are only interested in lung resection, okay? Then that could be a targeted POF, participant use data file. It's good for quality-related projects, and a limitation is we only get 30-day morbidity and mortality outcomes. So if you want longer follow-up, then we might need to go and use Medicare or market scan where you get a longer follow-up. The advantage is it has very detailed information about surgery complications and very detailed lab test results, which is often not available in, say, Medicare data. Another example is the National Inpatient Sample. This one, the adult version of it, it has limited information about each visit. It is obviously not as detailed as NSQIP. For example, lab test results, very detailed complications, these are not available in here, but it is national. And it has information about patient demographics. It also gives hospital ownership, ICD-9-10 codes, discharge status, and length of stay. And it's important to know that this data, you can't link visits from the same patient. It is at the visit level. So let's say the same patient come in 2 or 3 times to this database, we would just see different record lines, and we don't know it's actually from the same patient. And the other HCOP databases are in ways similar. Although these are national databases, and you can probably see in this map, these different databases might cover different states. Another example is National Cancer Database. And this database includes the identified patient level data. It does not identify hospitals. When they collect it, they actually have it, but they do not provide it to researchers due to the confidentiality issues. And it includes only COC accredited cancer programs. And they are submitted to American College of Surgeons. It includes information about demographics, tumor characteristics, hospital characteristics, but not specific hospitals. And it includes treatment and survival. But the survival here is, I need to note that it is overall survival. So that's what's different between the NCDB and the SEER registry. The SEER registry actually gives the cancer-specific survival. So whether the patient died of cancer or other potential causes. And this is important because cancer patients are often old, and their survival is not only dependent on their cancer outcome, but also other cardiovascular outcome, for example. And so SEER and NCDB can serve different purposes in research. And again, this one also doesn't have hospital characteristics. The PHC4 data is a Pennsylvania-specific database, and we have discharge data from almost all hospitals in Pennsylvania, except the Veterans Hospital, I believe. And we have very detailed information compared to HCUP NIS, which we just talked about. It has more detailed geographic information. So these examples are just trying to show that each database has its own advantage and disadvantage. And for different purposes, we choose different databases. A few practical tips. IRB exemption is often what we aim for many public databases, the national surveys. Often you can get an IRB exemption. And then for some databases with potentially identifiable patient information, we need IRB review. For example, the SEER Medicare, because it includes some potentially identifiable data, we need IRB review. Data acquisition process varies significantly, with some needing detailed analysis plan, protocol, and month of time, while others, you just go online, sign the DUA, the data user agreement, and download it. It can be happening in one day. For example, the SEER Medicare, we need to submit very detailed analysis plan. I remember there were reviewers once that came back and asked for specific ICD-9 and ICD codes that we're going to use for our research. It's almost like writing a paper already. And the whole process can take 5, 6 back and forth, review, re-review. So when you do studies using these databases, we have to allow extra time because of the long review process. And the cost of data also has a very wide range. Some are free. You can download it from the national survey websites. Some of them can cost a lot of money. For example, market scan can be a big dollar bill. So statistical analysis for survey databases also need to consider survey weights and strata. And usually the national survey databases, Briffers and Haynes, these databases, they provide the survey weights and strata when you download the data. Okay, so now I'll give an example of database that's existing with application. So here I give an example of the use of SEER Medicare data. We talked about this database capturing cancer registry information linked with their Medicare insurance claims. That way we have detailed information about tumor characteristics and also their healthcare encounters. And it's important to note that for using SEER Medicare, we have to make sure that we use a sample where there is complete information and patients have SEER registry, but not only SEER registry, but also Medicare Part A and B enrollment without the HMO plans. Otherwise, their healthcare encounters will not be complete. And in this study, we look at prescription drugs. Therefore, it's important to note that prescription drugs does not go back before 2007. So this study, we're looking at impacts of hydrocodone rescheduling on prescription opioid use in older patients with breast cancer. The basic background is there have been numerous policy efforts to prevent opioid misuse. And one of the important policy changes is the rescheduling of hydrocodone, making it harder to get, basically. How the policy change affected opioid use in patients with cancer is understudied. There are many studies looking at non-cancer groups, but how it affects patients with cancer is not known. So we aim to examine the impact of hydrocodone rescheduling on prescription opioid use and non-opioid pharmacotherapies in patients with breast cancer. The cohort includes older adults diagnosed with local stage breast cancer from 2011 to 2018. We required a continuous enrollment. This is a caveat of using Medicare data. More recently, there are new databases that include more details for patients who have Medicare Advantage plan. So that is the HMO plan, and we're working on some projects using the Medicare Advantage plan linked with SEER registry, but that's in the works. Patients without surgery or had autopsy or death certificates during these time periods are excluded. Again, these take sort of experience and knowing the literature, what patients we need to exclude. In this case, if patients are diagnosed at autopsy, obviously it would not be relevant. The key variables of interest, we look at the use of hydrocodone, and we also look at the use of either opioids because we're interested in seeing the impact of policy change on not only hydrocodone, but what people are doing. Are they replacing hydrocodone with other opioids, or they are using more non-opioid methods of pain management? In this study, we also look at morphine milligram equivalents, which is basically a measure of dosage. They're not equal, but basically we're looking at how strong how long, how much opioids they're taking. And then there's the use of non-steroid, I'll just call it NSAIDs, which is another option for pain management and antidepressants. We control for these factors. This is a very basic list of variables that may have impact on patients' decision to take opioids or other pain management strategies. So here we see the advantage of using existing database. We get a huge sample size. For example, here we get 52,000 elderly patients with breast cancer. And with the large data, we can see the trend pretty well. So in 2014, there's a policy change, and we see there is a drop in the use of hydrocodone. And we also see an upward trend for non-hydrocodone. So it tells the story that patients after this policy change were less likely to use hydrocodone, but more likely to use non-hydrocodone opioids. And our logistic regression results confirm our sort of visual inspection. We see that patients are less likely to use hydrocodone after the policy change. And they're more likely to use non-hydrocodone. There were not much change in NSAIDs use and antidepressants. And in terms of their dosage, we see less dosage for opioids. So our conclusion is rescheduling of the hydrocodone decreased the use of hydrocodone, increased the use of non-hydrocodone, didn't make much impact on other non-opioid pain management strategies. And overall, the dosage decreased. Here, I want to gratefully acknowledge my wonderful collaborators, Drs. Leslie, Ikram, Joe, Saunton, and Dr. Klein. And also acknowledge the funding by NIH, NCI, NIDA. Okay, the next example is a machine learning example where we use quality improvement program data. This is the metabolic and bariatric surgery accreditation and quality improvement program data from 2016 to 2020. And again, acknowledge my wonderful collaborators on this publication on here. So we know bariatric surgery is increasingly performed for severe obesity. Although mortality rate is low, it still carries significant risk of complications. The data, since this talk is about existing data, I'll talk a little bit more about the data. The bariatric quality improvement program data is the largest database focused on bariatric surgery. It holds records of about 200,000 cases performed, and we have pretty detailed patient characteristics, the lab value, their smoking status, the age, gender, ethnicity, all these things. And we also have detailed information about their surgery characteristics. On top of that, there's also information about the medical specialty of surgeons, operative time, year of surgery, and so on. So here we use a machine learning algorithm. We used a simple logistic regression as a benchmark, and then we ran random forest, gradient boosted tree, XGBoost, and we did some data undersampling of negative cases because complications are rare. So these are sort of important to do for machine learning projects where we have rare complications, rare outcomes. We use 80% of the data for training and 20% for testing. We look at the importance of each variable generated by the best model. And here's the part that I'm most proud of. We looked at the health equity by looking at the model fairness, because racial disparities in complications from the bariatric surgery has been widely identified. We look at the model fairness of these machine learning algorithms by looking at these two metrics, the EOD and the DI. And it's interesting that we find the simple logistic regression has the best fairness metrics for race, while the GBT has the lowest fairness. So we tried 3 different strategies to mitigate the bias. We tried removing the race variable. We tried undersampling the white patient group, and we tried oversampling the non-white group. And what we found is removing protected attributes, in this case, removing race variable, or oversampling the non-white group did not help, while the undersampling of white group actually leads to some improvement in the fairness metrics. Okay, so the last part of today's talk, implications of observational studies. What is the use of observational studies? It can have very significant, important clinical and policy implications. We can generate hypotheses for future trials. Observational studies can help us in generating new topics of research for future trials. It provides real-world evidence to supplement clinical trials. So these two kind of are complementary to each other. It could be that you don't have a trial yet, but you suspect something is more helpful, so you do an observational study. And then it could be that clinical trial has been done, but we don't know how well it's working in the real world on older patients, on patients who have certain different profile of disease. then the real-world evidence can supplement the clinical trial. The observational studies can provide long-term surveillance. It can help us develop personalized medicine. It can help identify populations at risk. It can evaluate impacts of policy, like what we did. We look at the impact of rescheduling of hydrocodone and look at the impacts. And it can also provide insights on disparities. So here are some examples of clinical and policy implications. We've probably seen a lot of studies using observational real-time data and get some idea about the impact of COVID and how things are changing during that time. So that's it for today's talk. Thank you very much. Please feel free to contact me if you have any questions.
Thank you, Dr. Shen. This is a wonderful, very informative presentation. There are a lot of materials. I believe our audience would have some questions for you in the future. But here, we still have a couple minutes. If somebody would like to ask questions here directly, please go ahead. You can unmute yourself if you want to speak. I see one. Is that okay? Thank you for the okay. So that's not a question in the chat box. That's not a question.
I know I've crammed a lot of material in today's talk. Feel free to ask any questions, contact me later or whatever. Yeah.
Can I ask one quick question? I know the Trinetics and National Inpatient Sample, they are available through the Penn State, like the Trinetics and the NIS. Do you know any other one which we can get access without having any funding or anything? I know some of the take like market scan.
Market scan can cost a big chunk of money.
Yep, that's any other. Do you know that, like, I'm on the behavioral health? Do you know anything which I know which are freely available and with the like not too much complex methodology wise, I can do some of them?
Yeah, so I have listed out a list of sort of, I think this is the very dense slide that has a lot of information. I have used all of them on this page. Like I personally used all of these.
Okay.
So if you have any questions or I don't know, research interest in using any of these, you can contact me.
Thank you.
Yeah.
Any more questions from audience? No. Okay. So let's wrap up the seminar talk today. Thank you so much, Dr. Shen, for taking time presenting here. This is a very helpful session for all the clinicians. Thank you so much.
Very much.
Yeah, thanks everyone for joining us. We hope to see you again in 2 weeks.
Thank you, Len and Junja, for hosting this and inviting me.
Sure, our pleasure. All right.